Hello, everyone. I'm your host for today's event. Thank you for joining us. I'm Jason Mouabbi, a breast medical oncologist at MD Anderson in Houston, Texas. And it's my great pleasure to be with two wonderful discussants. We have Dr. Irene Kang. She's an assistant professor at the Department of Medical Oncology who specializes in breast cancer. And she is the medical director of Women Health at City of Hope in Orange County. She has a special research interest in molecular characterization and investigating new treatment in breast cancer. And also, it's a great honor to be joined by Dr. Ruemu Birhiray. He's a board-certified medical oncologist and hematologist at Ascension St. Vincent in Indianapolis. He has participated in multiple research and has published multiple peer-reviewed papers. It's truly a great honor to be here with the legend in today's discussion. Thank you both for joining us.
Thank you.
First, we're going to start with the unmet need in the early stage HER2 positive breast cancer. Dr. Kang, this idea of achieving pCR as the ultimate goal started in the mid 2010s, right? And it was a big inflection point. All the study design has switched to design studies to achieve this pCR because achieving pathological complete response was made seem as the holy grail, is what's the great equalizer. We need to get our patient there. Very little neoadjuvant treatment was done before those landmark papers that show that pCR patient has better outcome, and after that, everybody is trying to give neoadjuvant treatment. What can you tell us about achieving pCR? Is it truly the great equalizer? Does it eliminate the baseline stage of the patient?
I think my thinking about this has really evolved over time. It's a wonderful, I think, prognostic indicator when, we may not, it certainly refines the way we think about a patient's prognosis. So achieving pCR, pathologic complete response, is certainly associated with better outcomes, improved outcomes. But what's been sort of changing for me in the recent past, and, thanks to some of the research that you've highlighted, Jason, is that, yeah, absolutely, that pCR is not the same for everybody, and that to some extent, stage at presentation does impact the prognosis on top of whether pCR was achieved or not.
Yeah, like you're referring to the Mecklenburg paper in JCO. That was really an eye-opening paper.
Huge.
Because we all knew deep inside that different stages have different prognosis. That's why the staging is one of the most important prognostic factor, right? Yet we came into an era, especially when I was a fellow, they told us, oh, pCR, it doesn't matter, you're stage 1 or stage 3, you achieve pCR, exception responder, you're gonna get. But when I started practicing, I thought, oh no, it's not true. So when you see a paper like that reaffirm what we've seen in clinical practice in an objective way, it really changes our thinking. Dr. Birhiray, what do you think? Like, how do you talk with your patient about this achieving pCR? Is it truly binary for you? pCR, excellent outcome, non-pCR, bad outcome?
No, we all know in medicine, nothing is ever binary, right? It's additional data. That's all it is, and I think we oversimplified it, like you said, either in our teaching, in our understanding of it, and even in our communication with patients. That, oh my gosh, if you achieve the pCR, you're going to live forever and the world is going to never end. But that is not true. Yes, you will do better, but it doesn't tell the whole story. So when I talk to my patients, I celebrate their pCR because you don't want to minimize it. And if they don't, I also don't necessarily make them feel like they are going to die. But once I've done that, then I remind them that there's still a risk, and that residual risk hasn't gone away, and that risk was probably like you were talking about the Mecklenburg paper, which emphasizes the fact that their original pathologic characteristics were still important. They were better now. And then make sure they buy into the idea that their therapy doesn't stop. And I also think that you should say that even before you ever treat the patient. So the patient doesn't come off with the belief that a pCR means everything is done, you've cured them, and let's go home and dance.
Fantastic. Very insightful. When we talk about HER2 positive disease, especially when we talk about the early stage, that special type of breast cancer does have a predisposition to end up in the brain. Truly, unfortunately. And it's really under discussed, in my opinion, with a lot of the patients. Can you give us some insight or shed some insight about what's unique about this type of breast cancer, and why is there a predisposition to end up in the brain? And is it a late event, or does it happen from the inception of that cancer?
This is a really, unsolved and unmet need in this subtype of breast cancer. We know that HER2 overexpression predisposes to simplify it, things like invasiveness of the cancer, that the cancer is better able to invade in areas and including entering in through the blood-brain barrier into the brain or the CNS. It can also establish more of a vascular supply in the CNS. And when does this happen is sort of unclear, but it does happen with sort of an alarming frequency in HER2 positive breast cancer. So the statistic is for metastatic disease, so for patients who already have stage 4 HER2 positive cancer, that up to about 50% of patients will eventually develop brain metastases. For early stage HER2 positive cancer, of course, that's not the case, but certainly the risk of metastasis is present for anybody with an invasive cancer. And then sort of coupling that with the tendency or the proclivity of HER2 positive disease to spread to the CNS, it's always something that I tell my patients. I have a low threshold to image the brain. So if you're having a headache or some sort of visual change, these are sort of symptoms that we really want to key in on. Sometimes we even screen without symptoms if there's sort of high-risk disease, say an inflammatory presentation. So I think it's a bit of a puzzle, but certainly something we keep close eyes on. We know the brain is a sanctuary site in general, and that a lot of our best drugs for HER2 positive disease, these monoclonal antibody-based drugs like Herceptin or Trastuzumab, Pertuzumab, TDM1, Trastuzumab deruxtecan to some extent, but that the antibodies don't really cross the blood-brain barrier that well. So it's possible that even though we have very effective HER2 positive treatment, we're not treating or protecting the brain.
Is there any guidelines to screen patients with HER2 positive disease for CNS recurrence? Are we there or not yet?
I don't know that we are there. And I'll tell you why, it's such a challenge. Obviously, you make a diagnosis of brain metastasis and you weren't screening and your patient comes in with symptoms. The patient is sort of looking at you like you failed, and you might even feel like you failed them. But the truth is this: what is early stage disease? Early stage disease is not the presence of brain metastasis. And we don't know that a diagnosis of brain metastasis in a symptomatic patient necessarily has a different outcome compared to a patient who is totally asymptomatic, who is screened, and you find brain metastasis. So there is the tension that we have. So I think it's important that we're aware that these patients have a higher chance of brain metastasis, and so we should have a lower threshold for imaging them. But our focus really should be, what can we do to protect that patient from developing, brain metastasis? I like that word protect, because that is really the intent. It's not finding it because you wouldn't have protected that person.
Mm-hmm. No. So CNS is a big issue for HER2 positive disease. Are the patients that achieve pCR protected from recurrence in their brain?
I mean, I think this gets back to our changing thinking about pathologic complete response. We have all this data about favorable prognosis, but and we do know that CNS recurrence actually is slightly less for patients who achieve pCR compared to patients who don't achieve pCR. But similar to, I think, our earlier question in the Mecklenburg paper, pCR does not protect against CNS response, unfortunately.
Can you tell us a little bit more about the Ferraro paper from the Sloan Kettering group?
So in the Ferraro paper, we found that patients who achieved pCR and did not achieve pCR, their rates of CNS recurrence were the same. And unfortunately, in patients who did achieve pCR, 4 out of 5 patients, those metastatic recurrences were in the CNS, so a really high proportion, suggesting that even with pCR, you don't get that sort of brain protection.
Yeah, and this for me, when this paper was published, it was a sobering reality. We all seen those patients where, like you said, I celebrate my pCR too,
Yes.
and we sit in clinic, we're celebrating,
Yes.
right? It's a beautiful thing, and I don't discount that achieving pCR improve outcomes, but it's not a full proof. It's not a full protection, and we've seen those patients that we celebrated, and then a year and a half later, we get this call that this patient is in the ER because of seizure or like breakthrough nausea that's unremitting, not working, and then they find something in their brain, which is heartbreaking. And the more we practice, the more we're gonna see those cases. So you're right, pCR is great to achieve, but it doesn't protect, especially when it comes to the CNS. Dr. Irene, back to the idea of those descriptive analysis. There was some descriptive analysis, mainly in the population who started Neratinib within a year of adjuvant Trastuzumab, and another sub-descriptive analysis in the patient who had residual disease, so receiving adjuvant treatment, had residual disease, then received Neratinib within a year. What was striking for me in those data is is how much better the outcome are in the patient who completed the 12 cycles of Neratinib versus those who did not. I mean, you can see in terms of even of overall survival, there was a threefold decrease in the overall survival in patient, although there were only 30% who couldn't finish those 12 cycles, but those 30% of patients reduced the overall survival of the overall population by threefolds. So what can you tell us about the importance of, if you're gonna start Neratinib, finishing the 12 cycles and not stopping early?
I think that's such important data for us to take home to the clinic and for us to be able to communicate to patients. 12 months can be a long time to be on a therapy, but we have now tools for how to improve tolerability, how to reduce diarrhea and prevent grade 3 diarrhea or severe diarrhea. And so we have to be able to help patients stay on treatment because, right, that year of therapy is what matters and what's going to confer benefit to our patients. So I think, patient education from the get-go, and for us also to be prepared to sort of support our patients and not give up early.
Yeah, I think it's also important for the patient to know those data, right? So they can get buy-in, so they understand the year is what's gonna protect them, not just taking the drug for a few months. Yeah. Dr. Birhiray, I want to go back to the CNS discussion. So as we saw all the other drugs that we have, like if you look at the affinity, which yes, it's a study for pertuzumab, but it also included trastuzumab and chemotherapy, right? So for me, it's a dual HER2 direct antibody plus chemotherapy that showed no improvement in CNS recurrence. And we have the Catherine study with the ADC that also did not show. In fact, it was worse on the Catherine study. Is Neratinib the only drug that can reduce CNS recurrence? Do we have this data from the Extenet, and what can you tell us about it?
Yeah, so we have that data from Extenet that shows that patients who got Neratinib, if you go, so let's go to the patients that were who got the most benefit in Extenet, which were the patients who were hormone receptor positive, who did not achieve a pathologic complete remission. If you were to just look at that subgroup, there was a 50% reduction in the likelihood of brain metastasis in that subset. So that's one bucket. If you look at the entire group, there is a reduction in the risk of brain metastasis. And it's not shocking, because when you look at data, right, you have to ask yourself, why am I seeing this data? If it doesn't make scientific sense, then you have to question the data even a little bit more. But the reason why I say it's not shocking is that this is a drug that has a different mechanism of action. It works intracellularly. It's a small molecule. It's able to cross the blood-brain barrier that may not be possible, or maybe not as robustly, with the monoclonal antibodies. So it makes sense that this drug with a different mechanism of action will do that. At this point, this is the only drug that is approved. Lapatinib, which, as you know, was a similar drug, was tested in different trials, and the trials did not show an improvement. Tucatinib is being evaluated. We don't have that data. So at this moment, this is the only drug that we have that can do that for our patients.
Yeah. I think for me, the biggest telling point is when you look at the 5-year cumulative CNS recurrence and you stratify it by pCR status, in the patient who have residual disease, the chance of getting CNS recurrence was less than 1% after neratinib. And I can't help but think about the Catherine study at that point. 7%, less than 1%. Like the 7 less than 1, 7 less than, I mean, for me, this is like screaming data, right? Screaming data about the importance of using neratinib. And on the other side also, the pCR patients, I mean, there was 0 reported CNS recurrences on the patient who received neratinib. There was no report of CNS recurrence. And that's another thing that's also big, you know, like, even if you got 1, you'll be like, okay, it happened. But there was 0. 0 speaks volume, having no CNS recurrences. So definitely we agree, neratinib is a very important drug to have as a tool for our patient. But let's talk about the elephant in the room now. The story about neratinib is not complete unless we tackle the problem of diarrhea. Diarrhea is the big problem, and it's the main challenge. Dr. Kang, I'm going to start with you. What is your way to approach the diarrhea and mitigate the chances of having diarrhea?
So this is certainly where I applied the control trial that really, helped guide and develop, several treatment strategies that optimize patient tolerability and minimize diarrhea on neratinib. What really stood out in the control trial were the 2 arms that used a dose escalation strategy. So there was a sort of 2-week dose escalation strategy as well as a 4-week dose escalation strategy. One, you started at 3 pills a day and then slowly escalated up to full dose 6 pills a day. And the other, you started at 4 pills a day and escalated up to 6 pills. And I think whichever one you choose or where I land on in clinic sort of is a discussion with patients and sort of how fast they want to escalate. But key here is that you start low and you ramp up to sort of maximize tolerability as well as adherence. It really minimized, diarrhea and especially grade 3 diarrhea in the first couple of months. And then what we see on neratinib is that generally that's when you hit sort of severe diarrhea. And then after month 2, you're really not going to see sort of flares or surges in diarrhea. And so once sort of accessing good control and good tolerability in the first 2 months are key. And I use the dose escalation strategy.
Fantastic. I have a follow-up question, if you don't mind. Do we have to get to 6 pills to get the full benefit of that drug?
We do know that from the control trial that, patients who just were on drug for, 12 months, that I think that's the sort of ideal.
Yeah, I can tell you in my practice, I rarely have 6. I have one case, that patient, I took her to 6 pills that had 0 diarrhea on every single dose escalation. So then I was like, okay, we should go to 6. But I truly feel the sweet spot maybe is 5 pills. 5 pills really keep you away from trouble. I have some patients at 4 pills. I think 4 or 5 are still pretty effective dosage. We don't need, I think the message should be there to the treating physician that 6, maybe it's too much. And
right, I don't feel the need to
yeah, we shouldn't, yes, we shouldn't. If patients are having already enough, like they got their sweet spot at 5 pills, you have a statu quo, take it. Don't push your luck.
Get to 12 months, right?
Yes, get to 12. I like that. Yeah. Get to 12 months. Don't try to push. Dr. Birhiray, can we talk a little bit about what other medications we have to help manage the diarrhea? Mainly, I want to focus on, there's a lot of drugs that we can use. There is the loperamide, there is Lomotil, there is cholesterol, there is other drugs like budesonide and stuff that you can add. What is your favorite approach when it comes to this, to the management?
My favorite approach is not to add anything, frankly, but but loperamide is probably the one that I use the most when necessary. And it's amazing when you ask patients, are you taking your loperamide? Oh, I forgot. You get a lot of that. So re-emphasizing to patients to take their medication is important. My nurse practitioners, when they're seeing my patients, they like to use Lomotil or diphenhydramine atropine. They seem to think that it's more effective. I don't necessarily buy into that, but that's what they will do. And I don't like doing that because it's a controlled substance and I have to write the controlled substance prescription, which I hate to do. So my preference is the dose escalation and loperamide. The cholesterol and budesonide, yes, they are there, but I think that's just, I try to really avoid using them, but if necessary, I would.
Yeah, you know, my problem with loperamide is that I tried it before, so I'm very biased against it.
We all have biases.
It's such a bad medication. I mean, you're essentially replacing diarrhea with a sledgehammer. It's truly a sledgehammer. Like you feel very constipated, very bloated, severe crampy pain. What happened with our patient is that, and this is my theory, and I did prove it because I asked a few patients about it, is that they try it, like, you know, when they start Neratinib, if they have a loose bowel or like a diarrhea that's not that bad, they try the loperamide and be like, oh my God, this is much worse than the diarrhea. And then they be like, okay, we're not going to use loperamide unless the diarrhea is bad. And then they're trying to play catch up. And playing catch up is not going to work, right? You need to be proactive with that drug. Lomotil, yes, is a controlled substance, but I found that it does not give the severe constipation that loperamide does. At least that's my clinical experience. And that's why I tend to do it. And yes, I don't like to give controlled substances, but thankfully I only have to do it for 1 month for those patients. And you're right, because like you said, Dr. Kang, is the diarrhea problem is the first month, right? You control it, it should be cruise control from there. So if we can control it, be proactive about it, that's the best way. So Dr. Kang, when is the sweet spot to introduce that drug? And it's a two-part question also. I want to also get into, like, do you have any problem getting it covered by insurance?
Yeah, two really good questions. The best time to introduce Neratinib, that's such a fraught, I think, question, and it's of course going to depend on your discussions with the patient and sort of where you think it's sort of appropriate to bring into the conversation. Like, certainly when you're first talking about neoadjuvant therapy, I mean, there's such a long road of treatment ahead. I think it doesn't really register even if you mention it. I mean, sometimes you're at a point where even talking about the year of adjuvant trastuzumab-based therapy doesn't really register. So I think you have to sort of read your patient. But I also know that mentioning Neratinib, just as you're finishing, 1 year of trastuzumab or TDM1, et cetera, is not the right time, because that's when patients are sort of ready to celebrate and cut the cord. And, you can't say, okay, let's do another year of a drug. So it has to be somewhere between that. And I find that I like to do it where, let's say, we're getting on adjuvant Herceptin Perjeta, we're getting on adjuvant TDM1 especially. You've had this discussion of increased risk or CNS metastasis. Once they're sort of steady on their TDM1 or their Herceptin Perjeta, then I say, hey, you've been on this drug for 3 months now. We've got, let's say, 6-8 more months left. When we finish, I want you to know there's an option for you that we're going to continue to talk about later. There's a pill that you can take for an extra year. It's, I think it's key to mention that it's an option to put that sort of patient ownership into this decision. And I like to mention it then, because then we've had a couple discussions by the time the year finishes and they're sort of ready to make that decision.
Yeah, I think, like you said, it's important to start early. What I like to do it is that, like Dr. Birhiray, I celebrate my pCRs. I absolutely do. But I leverage that celebration to offer Neratinib. I'd be like, see how happy we are right now? I want to keep you there. I don't want the cancer to come back, because if the pCR patient, if they're going to reoccur, where are they going to reoccur? In the brain. 4 out of 5 of those patients occur in the brain. So I tell them I have a drug that can protect the brain. And that's where I offer it. Now, the patient with residual disease already understand that they did not eliminate that cancer. And this is where I also introduce the 7%. Like, I want them, like, we're going to do TDM1, but there is 7% chance despite TDM1. But guess what? I got you. I have a drug for you after to reduce that risk to less than 1%, hopefully. So that I leverage those meetings to present, because the sooner you present it, it's in their mind, they know it's coming. The later you present it, they're ready to finish. Right. They see the finish line. You're not going to take that away from them at that moment. Yes. So I like starting early. So a lot of studies are going to be reshaping that space, the adjuvant space of HER2 positive disease. I want to start first with you with the DESTINY-Breast05. Can you tell us a little bit about this study and how it might change the field?
All right. So DESTINY-05 at the time we're having this conversation, has not been presented, but there is a press release, and it's going to be presented about a week from today. And that data is expected to show a significant improvement in the likelihood of recurrence when compared to TDM1, and will probably make TDM1 no longer the standard of care, and it will become the new standard of care in reducing the risk of recurrence. But what is DESTINY-05? DESTINY-05 is a study with Trastuzumab deruxtecan. So it's another ADC. It's a superior ADC, which we already know, to TDM1, so it's not shocking that it will be superior to TDM1 in the adjuvant setting. But still a monoclonal antibody-based therapy. It's still based on Trastuzumab, which we have discussed extensively, has limitations in terms of being able to get into the brain. So there will be people who will say, well, this Neratinib has not been studied in this group of patients. The truth is this, that's when you go back to your biology. That's when you go back to the science that drives everything that we do in oncology. If you wait for every data to reflect everything that we do, then we will never move forward. My argument will be that, yes, we would maybe, instead of a 50% reduction, we've reduced the total risk to 70%, but the CNS risk remains, and there's still a residual risk that the extended adjuvant therapy gives you with Neratinib. So that would be my speculation and my argument, even after the data is presented, no matter the results of the data.
Fantastic. Dr. Kang, how about there is another study that we don't know when it's going to result. It should be soon. I'm hoping in the next few years. This study has been going on forever. It's the COMPASS-HER2 RD. Can you let us know a little bit about the study design and what it's trying to achieve and how it might change the field?
This is also a very interesting design, looking at improving outcomes in high-risk patients who have residual disease after neoadjuvant therapy. At the time of the study design, standard of care is adjuvant TDM1 for 14 cycles, and the study COMPASS-HER2 RD is looking at randomizing between TDM1 plus tucatinib. Tucatinib is a different tyrosine kinase inhibitor, small molecule inhibitor that works intracellularly and blocks HER2. And so doing a year of TDM1 plus tucatinib, is that going to further reduce risk of recurrence in this high-risk population that had residual disease? And then because the mechanism of action of tucatinib is relatively similar to Neratinib, although there are small differences between the two tyrosine kinase inhibitors, I think I'm very curious to see if it's going to reduce CNS recurrence as well. We don't have that data yet.
No, we don't have that. It's been a long time coming. So now I have a question for both of you. The one that's challenging for me, yes, those two studies are exciting. However, they're only focusing for the patient with residual disease at the time of surgery. Nowadays, we know with the therapy we have, we can achieve pCR in about 60% of the patients. And with the DESTINY-Breast11, we don't know the results, but from the press release, they're aiming somewhere upward of 80% pCR. So really, residual disease is going to be between 20 to 40% the way we see it. But you guys did discuss earlier on that even the pCR patients are at the same risk of CNS recurrence compared to our residual disease patient. Yet those are excluded from those two studies, from the DESTINY-Breast05 and the COMPASS-HER2 RD. So we don't know if tucatinib is going to help them or TDXD is going to help them in reducing their CNS recurrences. So I'm going to start with you first, Dr. Birhiray, and then Dr. Kang. Where do you think Neratinib is going to play? Is it going to still have a role when those two studies are eventually resulted and are available to us?
I believe so. Of course, we're speculating. And again, the reason why I state that so emphatically is that you talked about the fact that those patients who do not achieve a pCR will not be studied, so we won't have data. The only data we would have will be with Neratinib, so that's already there. And unless you show data that says compared to Neratinib, these combinations are superior, in the absence of that kind of data, then Neratinib remains an option for those patients. So I don't think that the studies are being designed to really answer the clinically meaningful question to me, and maybe they will never be, simply because the ball keeps moving. Where do specific drugs fit? But I still go back to the fact that we have data that shows that Neratinib, given in the extended adjuvant setting, can reduce the risk of recurrence, both outside the brain, but most importantly, the brain, because the other drugs just don't get there.
Perfect, perfect. Dr. Kang, do you have anything to add to that?
There's sort of additive toxicities with some of these regimens, risk of pneumonitis with Trastuzumab deruxtecan, as well as, a combination of tucatinib and T-DM1 at the same time. I would anticipate running into at least LFT abnormalities quite a bit, nausea with the combination. So, if you have someone who maybe doesn't complete the 14 cycles of Trastuzumab deruxtecan or tucatinib, you have this opportunity to use a drug by itself, so in its sort of best tolerated state, after for high-risk residual disease individuals, and then completely for the pCR population. We don't have data on using anything else outside of Trastuzumab and plus minus pertuzumab. So Neratinib still sort of is the only agent we have in that setting.
I mean, you both nailed it, and I like about the side effect issue. I'm glad that's the only thing I have to deal with. Neratinib is diarrhea, to be honest. It's drug related. You stop it, the diarrhea is gone. ILD can be permanent, right? And I'm really worried about that. The combination of T-DM1 to tucatinib, although we don't know the results from the early setting, but from the metastatic setting, the LFT is definitely concerning, and the pseudocirrhosis that happened, the caking of the liver that happened when you give this combination, that was already reported in the metastatic setting in the HER2 CLIMB-02 with the combination of T-DM1 to tucatinib, is concerning for me. I mean, yes, we want to cure our patient in the early setting, but we don't want them to be stuck with lifelong diseases that they have to deal with. So again, for me, diarrhea, I'll take it every day of the week compared to lifelong issues that can stick with the patient. But here we are at the end of our fascinating discussion today. This has been a wonderful discussion. We discussed pCR, we redefined it today. We talked about the landscape of HER2 positive early stage breast cancer, especially talking about the adjuvant setting. And we talked about the role of Neratinib and how it's cemented in the future. I really want to thank you so much, Dr. Irene Kang, and Dr. Ruemu Birhiray. This was fascinating. Thank you so much for joining us this morning.
Thank you.
Thank you.
This was fun, by the way.
Thank you so much.